Yeah, so we shall straight away go to the cases. So this is the first vignette that we will be getting in the case. My screen is visible, right? Okay. So this is and you need to, and I cannot go back to the Zoom chat box and see, right? So you just unmute, one of you unmute yourself and read out the scenario. So this is the first poster people place in the exam. Also, you get this small 4-5 line vignette followed by initial blood gas reports as well as some blood test reports. And the colored, that is the red colored ones are the abnormal reports, which will be same in the exam. So in the exam, you don't have to go look for the abnormal reports. It will already mark in red because it's a very time sensitive exam. Okay, so do not to make it easy. It will be like that only. Like the real exam.
Sir, your voice is not clear. It's not audible.
So why don't you just read out the scenario, and after that we can go to the next question. You will get around 10 minutes. So do not take 10 minutes. Just read it out a bit fast, and we can face the next questions. Remember that every line is important. Okay, so just because the time is less, you cannot just jump past the lines. I'm giving you some time to read the scenario and the blood test reports. It's 5:48 right now. And no 5 minutes. We can take up the case at 5:53. Everybody go through the scenario. Otherwise, it will be like a theoretical discussion. That is not what we want to edit. So this is 5:52. So one of you unmute yourself and tell me what is the case. Agree. But this will be an interactive session. Otherwise, like it's very difficult to proceed. Any of you just unmute and tell me what you read about the case.
Sir, this is a male patient with 73 years old male patient, possibly obese patient, presenting with post-op. He's a post-op case of abdominal aortic aneurysm repair. Presenting with hypoxemia, perhaps because FiO2 is 0.4 and PaO2 is 91, saturation 98% on FiO2 of 0.4. And this patient is also developing norepinephrine requirement, possibly because of ongoing sepsis, and urine output is low because of AKI setting in because of 3 hours clamp of the right renal artery. ABG is showing high in iron gap metabolic acidosis with hypoxemia, with elevated lactates and low SCBO2. TLC is high, 20,000 counts, with hyperkalemia and hyperkalemia setting in, and urea and creatinine are elevated, suggesting of acute kidney injury, and troponins are high, and serum CK levels are also elevated.
So this is what you have to note down during the first 20 around 20 minutes that we will get for the first case. So whatever you think is important, you have to note it down. You have to calculate you have to interpret the EBG, calculate the like with the metabolic acidosis, you have to calculate whether it is high iron gap, normal iron gap. You have to look for any compensations. This is the usual ECG EBG interpretation. And you have to also look out for the blood value that have been given, whether there is any hyperkalemia, whether any AKI, whether there is any features of myoglobinuria, any features of cardiac enzyme swing rates, any features of DIC, low platelets, sepsis, blood loss, these type of things. So we have to, so basically in the other part, that is the CCS, and that is the X-ray posting. That's a very rapid part of the exam. But they will get that part. So there you do not need a paper, pen, etc. But in this long test, short test type, you need a paper and a pen or a pencil, and you have to show it to the examiner beforehand. That will hand it. Otherwise, they will not allow you later. Remember it. Do not forget to take the paper and the pen before the exam, because the proctor, they will look how to do. And then you have to also show that you have this blank paper and the pencil and the pen, and you will note something down during the case. They will allow it. But just remember to show it to them. That is one thing. Secondly, use the paper and the pen and those initial 15-20 minutes to note down these topics, whatever you feel is right. For example, here, as I actually pointed out, there is an issue of post-surgical case. Receive lots of massive blood transfusions. So the case may go towards the massive blood transfusion, the hypothermia, and the metabolic acidosis coagulopathy part. The third point is there is an acute kidney injury setting in, so it can move toward the CRT or the hemodialysis part and API part, and there is also a shock component. So shock they can move anywhere. It can be cardiogenic shock, it can be septic shock, it can be hypothermic shock. So these are, and there is a then they are mentioned that they have that the patient has received 700 minutes of intrathecal morphine, and their right arterial was planned for a long time. So right arterial can for a long time, that may lead to ATM, and that can lead to some sort of other problems. So, and there are multiple past medical history problems. Remember that once the 15-20 minutes is over, you cannot get back to this site, to this slide. So note everything now that is there. Do not know what is found important later on. Suppose the last they ask you about the very difficulty. There you can tell that yes, the patient had a coronary artery disease, the patient is obese, these things. There after 4 digit deaths, you may not remember the weight of the patient. I mean, you will definitely not remember the weight of the patient if you don't know it down. So note these things down. That is why this 15-20 minutes is very important. And this will determine whether you pass this case or not the other class. Okay. So thank you, doctor, for pointing out these things. And now we move to the real questions.
Sir, your voice is not clear. We are not able to hear.
Yes, sir. Is the problem there for everybody?
Yes, sir.
Okay, because I can hear your voice very clearly. So just a minute.
Now is it clear?
Yes, sir. Much better. Yes.
Okay. So what I was telling was that this is a post-surgical case, right? So when you note these things down, you have to note everything down on a piece of paper, and you will need to show this piece of paper to the examiner. That is the proctor who will see your room and your the examination site and the surroundings before the exam starts. If you do not show that piece of paper, they will not allow you later. So you need to remember that firstly. Secondly, once you get this 15-20 minutes to read this case, then note everything down. Like here, there is a post-op case, massive blood transfusions, there is multiple comorbidities, and the intra-op there were two significant. One thing was this right renal artery prolonged clamping. Second one was 700 mics intrathecal morphine. Another thing was that that he is now going into shock, and he has developed low urine output and urea creatinine is raised. And the important blood groups which are typed also noted down: the high metabolic acidosis, high lactate, high glucose, SCVO2 is low, and high total count. Because once the 15-20 minutes is over and you move to this question part, they will not go back. So once this site appears, you cannot again go back to this slide. Okay. So if you do not remember something, then they will not tell you. Do not expect, they will not help you anyway. They will be very cooperative and friendly and everything, but they will not go back to this slide. So this slide will determine, so this 15-20 minutes will determine how you perform the long case of EDIC part 2. That is why this was very important. So now they have asked active issues at this point of time, and they are expecting a very to the point answer. 4 or 5 points. Maybe this question has got 3 points, and they have marked it as 1-1-1 or 2-1-1. So 4 marks. If you tell those 3 points, they will give you the 4 marks. If you tell 5 points and suppose you miss one of their points, then they will give you 2 marks. They will subtract the marks of the other point. So better is to list down all the active issues. So I don't think you have written down. So I am going back, but they will not go back to this slide. So tell me the active issues at this point of time.
High in iron gap metabolic acidosis, hypoxemia, hypotension and shock, hyperkalemia, acute kidney injury, and elevated CK levels, troponins are high,
Okay.
hyperglycemia.
Okay. Yeah. So this is the way to answer. Tell them everything that you have found out in the active issues, because usually the first question will always be an active issues, or it will be a summarize your case. If they will summarize your case, then I think it will be easier, because then nobody will miss much. But active issues, the main problem is that many of us, even me also, when I started preparing, and other participants, my friends who have given the exam this time, what they did was they told the active issue that they usually think like in an ICU. That is, firstly, they told something like septic shock, not mention septic shock. You do not know whether it is septic shock or not, firstly. Second was AKI, and third was handling the metabolic acidosis. And then they stopped. But suppose the answer was, one of them was, answer was hyperkalemia. They give very much importance to hyperkalemia, okay? So if the potassium level is high, 5.5, they are mentioning 5.3 as normal. So even if it is 5.5, and it is in red, that means it is also abnormal. Always mention hyperkalemia, because that will 99% of cases that will be one of the active issues at this point of time. So yes, tell everything that is there. So now, when we move to the next part of the question, you see how will you take care of the shock. So if you have not mentioned shock here, they will not give you marks, firstly, and secondly, they may skip this question altogether, because the exam is like that. Suppose there were 3 points, and they will not skip the whole thing if you miss this whole question, but their instruction will be skip one question if they do not mention any of these 3. So not only you will lose marks for this question, you also lose marks for suppose this question also. Anyway, suppose you are told that yes, there is a shock, and now you are being asked how will you take care of the shock. Answer it. Yeah, somebody just answer it. No? Just how will you manage the shock in the ICU? The answers are very straightforward and simple. There's nothing going on in the question of the answer. Just the exam pressure and how you handle the examiners and the situation. Anybody just try to answer this question?
I'll give fluid resuscitation.
No. This is exactly how you should not answer. Okay, this is a discussion, so no problem if you make a mistake. Do not stop telling I shall give fluids. Do you only give fluids and stop seeing that patient in the ICU? Do not do that, right? So how will you take care of the shock? First, tell that what type of shock it can be. What are you thinking? It can be a hypovolemic shock. It can be a cardiogenic shock. It can be a septic shock, right? The patient has come back from the operation theater. So it can be a hypovolemic shock or a blood loss related shock. The patient is undergoing a long procedure where the renal artery was clamped for a long time, and the procedure was a cardiac procedure. I mean, not a cardiac procedure, but an aortic repair of an aortic dissection. So it can be a cardiogenic shock as well. The third is a septic shock. The lactate raised, WBC is raised, and maybe the patient has developed some hospital-acquired infection already. However, the chances of in septic shock is less. So if it is a cardiogenic shock, giving fluids will actually harm the patient. So do not give fluids and stop, because suppose this question will not carry that much marks. This question will carry maybe a 3 marks. Suppose 3 marks for 3 points, right? So first point maybe whether the candidate is classifying the shock or not. Thinking about cardiogenic shock, hypovolemic shock, septic shock or not. Second is whether you are doing what do you usually do? You assess the fluid status. How will you do that? You will do a focus, you will do an IVC check if possible. If not, you will tell that there is possibly a central line arterial line already there because of this major post-operative case. If the lines are usually there, so you will check for the variations, right? The pulse pressure variations or the stroke volume variations. Tell anyone. So
patient is breathing spontaneously.
Yes. Tell me. Yes, that will be the discussion. That's why I told that it can be an IVC or it can be this or the third. So if the patient is breathing spontaneously and the patient is going into a shock, so will you let that patient breathe spontaneously or like you will deeply sedate the patient? Because once you tell the patient is breathing spontaneously, they will not always stick to this question. There is a chance of taking a 2 to 3 questions, because that way they will assess how much you actually, some extra points. Because in the answer sheet, apart from these marks, at the end there is overall performance of the candidate, that they will assess how you are overall managing the patient. Maybe you are missing 2-3 questions, a few points, but if you manage the patient overall well, like safely, well means safely, nothing high-fi, just safely, and like a senior registrar in the ICU, or a senior, or like a junior consultant in the ICU, because EDIC is not for the senior consultant, right? It is for the junior consultant or the registrars. So yes, as we are discussing, the patient is breathing spontaneously. So how will you assess the fluid status for this patient?
Sir, I will measure cardiac output using velocity time integral using echocardiography, and I will measure the change in the VTI after doing passive leg raising. If the increase in velocity time integral is by more than 10%, 10 to 15%, then it means patient is fluid responsive.
Fine. So yes, that is the answer. So how will you take care of the shock? Now, what do you know? Whenever they mention shock, like, don't mention all the 4 types of shock, right? Like here, neurogenic shock is impossible. So do not mention neurogenic shock here. Here, the other 3 shocks can be there. So tell them that first you will try to find out which type of shock it is, and tell the names. Second, you will assess the cardiac state of the patient, and you will also assess the fluid status of the patient. The third, what is the third point? Whether you will give fluids or not, depending upon obviously the fluid status. If it is a patient is fluid responsive, yes, you will give some fluids. If not, you will not give the fluids, and you will target a mean blood pressure of something like 65 to 70, and you will assess, and you will give the inotropes accordingly. This much it will usually be enough to mention that you are taking care of the shock. And so one was for cardiogenic shock, you are taking the ejection fractions, and you are getting a bit, basic bedside echo. But for the hypovolemic shock, you are assessing the fluid status, you are thinking about giving fluids or not, and you are also giving the inotropes in addition to the fluids. And what about the septic component? Along with this, you are thinking about giving some antibiotics or not. So that will how will you take care of the shock. This will be again a 3 to 4 marks. Each question there will carry a maximum 3 to 4 marks or 5 marks. Second is how will you address acute kidney injury. Again, if you are not mentioned acute kidney injury here, maybe they will skip this question. So you will not get the chance to get the marks. So tell me how will you address acute kidney injury. So once you see this question, any question, especially in these long cases, first you have to find out whether there is a classification available or not. If there is a classification available, like in the case previous question, classification of shock, here also there is a classification available, right? Classification of acute kidney injury. Classification does not mean based upon the uterine output, it means the pre-renal, renal, and the post-renal. So the first answer will always be, you will try to find out whether it is a pre-renal cause, renal cause, or post-renal cause. So what do you do to find it out? That is at the bedside, not any fancy tests. You will do a bedside, you have already assessed the fluid status, and you know about the oxygen status. So those are the 2 primary causes of pre-renal causes of acute kidney injury, and also you have assessed the heart. So tell them that you have already done these things in the previous question, and so the pre-renal causes you have ruled out or you have ruled in. Second is the basic bedside echo of the USG of the kidney. If you can do it, it's fine. Nowadays, USG kidney can be done in the by a trained critical care specialist, or just simply get a bedside kidney USG kidney done to rule out any renal parenchymal disease, or mostly to measure the CKM. That is the corticomedullary differentiation. The third is again a focus, put a scope on the bladder and find out whether there is an obstruction or not, and also about the quantity of the urine present or not. So in this way, just you do not have to measure all these things. Just to tell them that I shall classify the acute kidney injury on the basis of pre-renal, renal, or post-renal. I shall do that by assessing the fluid status of the patient, cardiac condition of the patient, oxygen level of the patient. I shall do an USG kidney bedside and I shall also rule out a postrenal obstruction. Okay, and then okay, so this was the first point. Now tell me, how will you address acute kidney injury? I have discussed about the first one, the classification part. Then tell me, what will you do?
In this case, a renal cause was more likely, that because the clamp has been placed for a long period of time, maybe 3 hours or so. So renal cause is highly likely, and I would like to stage the acute kidney injury on the basis of serum rise in serum creatinine and urine output.
Okay. Okay, so you have classified the patient. You are now to stage the patient on the as per the KDO criteria. That's fine. Apart from that, what else? So this remember, this is first point. So they will give you 1 mark for it, or maximum 2 marks for it, as per whatever they have. You still have 2 to 3 marks to score in this case, right? So what will you do apart from that? The usual AKI management in the ICU. Will you send some investigations? You have done an USG. You will send the urine REME, right? Urine examination, microscopy examination. You will address the fluid status if the patient is hypovolemic. If you think that the patient is anemic, you will give some more blood products. If you think that the cardiac condition patient is bad, then you will treat that. Because if the patient's kidney renal parenchyma is gone, then the treatment is hemodialysis, right?
Sir, since this patient is having hyperkalemia and urine output is also low, so
Okay.
I will consider starting some renal replacement therapy for this patient.
Why? This is the day 0 of the ICU stay, right? Post-op. Suppose you are in a you work in ICU, right? Everybody, all the 13, 14 candidates have worked in ICU, including me. So suppose you are standing in an ICU bedside and you receive this patient. Do you start renal replacement therapy immediately for this patient? It's not possible, right? Neither do you want it, neither it is possible. You give some fluids to assess whether the urine is coming or not, and you give some potassium correction, hyperkalemia correction. You send the investigations, you do the focus, you do the USG kidney, and then you wait for some time to see whether urine output picks up. As once you maintain the blood pressure in a 70 mm Hg range. Isn't that what you do in an ICU?
Yes, sir.
Yeah. So tell that. They want to know exactly that. They do not want to know whether you know how to start a CRT or not. At least not at this point of time. So tell how you address the acute kidney injury on a day-to-day basis. If they tell you that yes, the patient is in 3 days in an ICU and the patient is passing around 20 ml of urine hourly, 5 to 20 ml of urine hourly for the last 8 hours or 10 hours, then yes, you tell that yes, I will not wait and I will advocate for the hemodialysis immediately. Do not tell the hemodialysis, you will start hemodialysis directly. It will fetch you some marks, and basically it will not, there is no negative marks, right? But what happens is that at the end of the questionnaire session, there is a point, as I mentioned, that the overall performance, there you will get a negative marks. There is not a negative marks, but suppose there are 5 classifications of how you pass in the exam. First is exceptional candidate. Second is very good. Third is passed. Fourth is barely passed. Fifth is barely failed. Sixth is clear failed. So suppose if you have barely failed or barely passed, then that end remark becomes very important, because that may just carry you over the line, because we have to pass 2 out of 3 of these cases and 2 out of 3 of those clinical scenarios. Those chest X-ray ECG, there are also 3 scenarios. I mean 3 stations. So to pass 2 of them. So suppose if you are passed, suppose if you are barely passed with a good overall view, then they will probably pass you if you are passing another part. But if you tell this sort of answers, that I shall start hemodialysis directly, then they will not give you that opportunity. So that is a very important part. Nobody told me these things when I was preparing. During my journey, I realized these things. Anyway, so yes, addressing the acute kidney injury, what is the final answer? You will classify the acute kidney injury. You will address the, assess the fluid status. You will rule out the USG kidney. You do a USG kidney. You rule out obstruction, and you will give some IV fluids, and you will wait for the nephrologist's opinion also. Take their opinion, because the European sections, they depend upon these consultants and these opinions. And then and you will wait how the patient responds. This is what they want to hear till now. Okay. The third point is how you treat the hyperkalemia. Again, active issues is going on. Okay. So these were the three active issues in my case: shock, AKI, hyperkalemia. So tell me how you treat the hyperkalemia. This is a question where you cannot take time, because then you will get some more time for the next question, which will be a more descriptive ones. This is a clear-cut hyperkalemia management. You will take maximum get 15 to 20 seconds. They will wait for you for 5 minutes, but the time is only 25 minutes for the whole scenario. So tell me. I think everybody knows treatment of hyperkalemia is calcium gluconate first, followed by insulin restored infusion. And if it is not medically managed adequately, and if they are not coming, then finally we will go to hemodialysis. I'm not waiting for your answers. Just let's move on. Okay, this I will not tell. This you tell me. This is the anticipated problems in the ICU over the next 48 hours. See, once you reach this question, and if you have not noted the first scenarios down, then you will miss some points. So always note this scenario down. I am helping you guys because you have probably not noted it down. So again, go through the scenario and tell me, apart from the three existing problems, what are the anticipated problems that the patient is getting in the ICU in the next 48 hours. And this question carries 5 marks. There are 3 points. They will not tell you that in the exam, but I'm just telling you. So it will be not a descriptive answer, but a very to the point answer. 2 minutes. I shall come back to you after that. 6:18 now, 6:20 we shall discuss. Okay, guys. Somebody just tell me what are the 3-4 points that you think will develop in the ICU complications will develop in the ICU patients for the next 48 hours for this question.
Okay, let me just say a few things. It's possible within the next 48 hours for this patient to have worsening of his renal function and the metabolic acidosis. It's also possible for this patient to become hypoxemic from ARDS, and then other complications of massive blood transfusion like hypocalcemia may also develop. Okay.
Yes, doctor. What else?
Patient could require intubation and mechanical ventilation because of worsening hypoxemia. And there could be onset of sepsis and septic shock, which may require further progression in the vasopressors and addition of maybe a second vasopressor. And could be worsening of acute kidney injury leading to further hyperkalemia and decreased urine output.
So all the answers I told is perfectly right. But EDIC 2 is a very, it's a very, what you call it, common sense or a very common sense based question, right? So in an EDIC 2 long case, whenever it is a surgical case, so think about it. We are discussing a surgical case today. Even if not, it's obvious that it's a post-op case. So regarding that, what complications can develop? Oh, it's a post-op patient. So apart from the AKI,
Coagulopathy, bleeding.
Okay. So yeah. So see, you need to practice this post-op surgical patients in an related to EDIC case. You see, once you practice a few cases, then immediately when you see the first line, that the elective open abdominal aortic aneurysm repair, you will know that this case will probably go in a direction of something like either in an abdominal compartment syndrome part, or it will go in a ischemic abdomen part. Okay, because those are the two favorite questions parts of the EDIC 2 long cases. Okay, so whatever the two of you told, every point is right. Obviously, those things are correct. But as I told, it's a 5 marks. So basically 3 points. The first point was this either an abdominal we were thinking about ACS, abdominal compartment syndrome, or an ischemic abdomen. So that was carrying 2 marks. 2 marks for the acute kidney injury and 1 marks for the others. There are 3-4 points or. So if you tell any one of them, you will get the marks. So you will have missed the 2 marks for the acute abdomen case. And the issue is that not this. You will think that 2 marks is okay, but the So this was okay. So if the person who was presenting, so active issues, all three were told, so they will get full marks for that. So 4 out of 4. Take care of the shock. I told that you need to classify the shock. Acute kidney injury, again I told how you need to approach classification, some investigations, some referrals, and a few management options. Do not tell HG directly. Hyperkalemia, I told hyperkalemia, I think everybody will get the full marks. Here also I told here also I told the trick that what you should consider, because I know initially thinking of an abdominal compartment syndrome or a ischemic abdomen will be difficult, but they are expecting you to think about that, because that is why they have to 48 hours. Fine. So this was the end of the first case. Not the first case, the case based upon the initial vignette. So now they have given this vignette. You in the exam, they will from here onwards. The thing is that you will not get any extra time. So suppose you have got 25 minutes for the whole discussion. So the time you take to read this, to analyze the X-ray, again to get back and read it, and the time you take to read the question and the answer, everything is within those 25 minutes, out of which probably 7-8 minutes you have taken in these question answers. The time that you take to read this, they will not take in a 25 minutes, but from the moment they come to this site, it is 25 minutes. So the reason I'm telling you that you need to read this very quickly, and if possible, you may note down 1 to 2 points from here. Unlike the first vignette where they were moving away, because they will not move away from this vignette. And anyway, it will be 2 to 3 questions, so you will not forget this vignette. So yeah, just 2 to 3 minutes to study the vignette. Once you are ready, just tell me somebody, okay, and you can move to the, because yeah, you can move on, because that will be the way you will need to tell the examiner that yes, I have read and I am ready to face the questions. You need to be very confident to tell the examiner that, and after that they will move to the questions. Okay, I think everybody has read up the part and have seen the chest X-ray. Now we shall move to the question. So why the hypoxia here? Somebody tell me. Again, it will be like 3 to 4 points.
Okay, from pulmonary congestion.
1, then
Aspirational movement,
then
load overload.
No, it's also possible that is ARDS, but it's the X-ray picture is not very typical.
right. It's not ARDS, right? X-ray picture is not sensitive of that.
Right lower zone is showing some patch like.
Okay. So what are the 4 points here? Because you have to tell the 4 points, obviously, as per this X-ray and the clinical scenario. So one is fluid overload. Second is this new onset sepsis and hospital acquired pneumonia. The third thing, I think somebody told lung collapse or atelectasis, right? Yeah. So if somebody has told, that will be that. Otherwise, that will be one of the answers. What is the 4th point? You need to read the vignette very carefully. Why have they mentioned fentanyl, PCA, and sedation?
Over administration
Yes.
of fentanyl.
Yes, that is why they have mentioned the fentanyl, PCA, and sedation. And the causes of hypoxia were the 4 things which I mentioned. One of them was fentanyl over sedation. This is why practice is important. If you practice, you will immediately you get clicked, because if I did not know the answer, and I would have thought like you guys only. New onset sepsis, atelectasis, fluid overload, over blood transfusions, those things. I would have not thought about the fentanyl, PCA, and sedation. But
Yes.
they will give the
CCS can be there.
yeah. So but they give fentanyl, PCA, and sedation is one of the answers, and it's content 3 marks. If you don't tell the fentanyl, PCA, then you lose 1 marks. Okay. So you now know how to approach the hypoxia. Always remember that you have to find out the 3-4 causes from the scenario only. Why the agitation? They have mentioned the agitation. Day 3, the patient became restless, right? So why do you think the patient was agitated?
It may be because of pain. The
First-
post-op analgesia may be inadequate.
Okay, then there are 3 points. So first is this, second,
Hypoxia.
hypoxia, pain, third, just go through the vignette ones, otherwise I shall tell. It's so you see, these questions are the ones which makes EDIC2 very difficult because these are simple questions, but the answers are already written by them. So yeah, just go through it once and go to the Excel.
Hyperglycemia.
What?
Hyperglycemia. HHS.
Hyperglycemia. Okay, but no, hyperglycemia is not one of the answers. Okay. So embolism. Okay. Yeah. So you have to rule out embolism also. That is a good. So first point was this pain. Pain was an excellent answer because that was a difficult answer here. Then the other 2 points were, one was hypoxia, the third was sepsis. So yeah. So pain, whoever told you, it was very good. Pain is one of the answers here. Post-op patients, they will hypoxic or not hypoxic, restless, agitated. Always tell pain as one of the either pain or like less than prescribed drugs. And if they have already prescribed the pain medicines and then the patient become drowsy, patient become hypoxemic, some complications developed, always tell that maybe there was an over administration of the pain medicines. These are the clues. These are the ones that they expect you to answer. Because bedside, they want you to think along this line that whether it was a pain medicine error or not, because they give very huge importance to over administration of pain medicines or under administration of pain medicines. Pain relief is for them is like next to saving life. So yeah. So whenever they mention fentanyl, just give some more importance to it. So hypoxia, agitation, 3 marks. Not 3 marks. The difficult one had 2 marks, so 4 marks each. So now you know about the case. How will you, now the patient is sedated, ventilated. I'm not sedated, intubated, ventilated, and the patient is hypoxemic on a shock, and is still developing and still having a low urine output. So how will you plan to manage this patient? Think and tell me. This is a 5 marks question. So 3 for investigations, 2 for the next plan.
To repeat the renal functions as well as urinalysis to be able to establish a worsening renal profile. And if the renal function has shown significant deterioration, then we can quickly consider putting the patient on CRRT.
Okay. Yes, you are right. One part is right, that you have to assess the kidney functions and accordingly you need to decide. What else?
You also need to send blood
We can
cultures
get
and
an
inflammation.
ultrasound of the kidney done and evaluate for deteriorating renal function. Also, urine analysis should be done.
Yeah. The renal part is okay. Okay, the renal part is adequately answered. What else? Somebody was telling about the cultures.
Yeah, blood cultures and inflammatory markers also we need to send this blood.
Yeah, you need to assess the what we usually do when the patient worsens. We send a complete blood count. We send the liver function test, renal function test. Why liver function test? Because it can because their patient is hypo. If they ask you why do you want to send an LFT, tell them that the patient is hypoxic on shock. We need to see whether the oxygen delivery to the liver is okay or not, and whether the liver enzymes is raised or not. And obviously, you need to assess the kidney functions as has already been discussed. You also need to, what else do you need to do? You need to send the pan cultures. You need to send the 2 blood cultures on 2 sides. You need to send a urine culture, and you also need to send the patient is hypoxic, right? So you need to do a bronchoscopy, and you need to send a bowel culture. And if the patient is having lots of secretions, you can directly take an ET aspirate and send a culture. They will not expect you to tell this much. The investigations mean you will send some blood investigations, which will assess the total count, inflammatory markers, pan cultures, which will include this. You will assess the renal function by ultrasonography, by urine REME, urine cultures you already told, and what else? What other things? What other investigations you will do?
You can also send procalcitonin.
Yes,
And you can see the bladder pressure to see if there is any abdominal compartment syndrome is there or not. Where kidney urine output is low and EK is there. If there is any increase in intra-abdominal pressure, then we can do the measures to decrease the intra-abdominal pressure.
Okay. So yeah, you are thinking in the line of abdominal compartment syndrome and abdominal pressure is okay. What else?
Coagulation parameters
Why?
and
The patient is not bleeding.
See the electrolytes.
Electrolytes, yes, blood test. You will
Patient is having atrial fibrillation, so we have to do
very good.
the
You do the
electrolytes, the
ECG.
magnesium, potassium, calcium.
Okay, okay. Okay. What else? Investigation. Yeah, tell.
We have to see the
We will
hemoglobin
also
level.
need to optimize anticoagulation because of the atrial fibrillation.
Okay. So guys, you see, investigations has got two parts, right? Blood
Imaging.
investigations and radiological investigations. Radiological investigations wise, you have told about the USG kidney. And remember, in this case, you are working in the best hospital with the best equipments and everything is available at every point of time, right? That's an exam scenario in all exams. So in this case, we have already discussed that there is a chance that the patient may go into abdominal ischemia, ischemic abdomen. Somebody was telling about abdominal compartment syndrome also. So at least tell that you will do an USG abdomen to look for any collections. It's a post-op case, right? We always do that, right? USG abdomen, look for any collections. And we also do what somebody was telling about the coagulation parameters. But before that, we need to see whether the patient active bleeding or not. And yes, definitely send the coagulation parameters as well. And how do you assess the abdomen further? Next investigations has to involve a CT abdomen, not only a CT abdomen,
CT.
abdomen with a CT angiography. Okay, it needs to be a contrast CT, yes, contrast CT with a CT angiography. Remember that in this exam settings, presence of an AKI is not a contraindication to do a contrast CT. Regardless of what we practice, I practice, you practice, or in somebody else practice in their ICUs, in their hospital, individual policies, CT abdomen with CT angiography has to be the investigation of choice in this setting, in an abdominal post-op abdominal case. So, what are the investigations? Always classify as blood investigations, radiological investigations. Blood investigations, basic investigations, coagulation parameters, the cultures, and especially emphasizing on the renal assessment. And radiology investigations, yes, USG kidney, you can tell, and the CT abdomen, contrast CT abdomen with CT angiography, which will also give you an idea about the renal function, obviously. Why do you want to do this? You want to look for any collections, any abscess, and for any ischemic abdomen, any patient is AF, the patient is having a renal artery clamp, the patient had underwent a major abdominal surgery, abdominal aortic aneurysm repair surgery. So any one of them is present in your post-surgical patient, it is an indication to do a CT abdomen once the patient deteriorates. If all three are present, that needs to be the first investigation that needs to be done. Okay. So what I understood was that because we do not work in a surgical ICU as such, then these answers do not come spontaneously to us, right? So we need to practice doing this. Okay. And next investigations plan is as per the investigation findings. We need to correct the coagulopathy if there is any. We need to correct the sepsis. We need to start some antibiotics. We think that the sepsis markers are raised. We need to drain out the collections. If there is a bleeding, we need to consult a surgeon. We need to plan for a laparotomy, right? If there is a bleeding or if there is we think there is an ischemic abdomen. And do not forget an ABG. I don't think either me or you, any of you told about arterial blood gas, but repeat arterial blood gas, rising lactate. That is one of the first markers of mesenteric ischemia. So you are done. Because you see, you will not tell CT abdomen here. They will give you ask you that anything else once or twice, and then they will stop. They will not ask you more than that. And then in Vignet 2, when they come, the first line is CT abdomen. Then you realize that you messed it up. You did not tell CT abdomen in a post-op patient. and then obviously you cannot go back and tell that yes, I will do a CT abdomen also. But in your mind it will be conceivable that yes, I messed up, yes, I messed up. Do not do that. Suppose in the real exam also did not mention this obvious answer here, CT abdomen, or something you thought was very big and you missed it. The next weakness starting was that. Do not think about that. It's very difficult. It's easy for me to say once I have passed the exam. It's very difficult for you guys, especially in exam setting, but you have to try to do that, because this vignette is carrying once again carrying 2-3 points and around 8 to 10 marks. Do not let go of that. So what have they done? They have done a CT abdomen. There is no evidence of bowel ischemia, but there is a right lower lobe pneumonia with infection. There is no PE. The bowel has grown Pseudomonas aeruginosa. Antimicrobials are targeted for this. On day 6, the patient is worsened, hypoxemic, noradrenaline requirement gone up. Abdomen is still clinically benign. Enteral feeding had been tolerated. The urine output is this over the past 8 hours, and the blood gas investigation have been done. And I'll tell you, there is still a metabolic acidosis component. Lactate is still high. The albumin is low. The liver enzymes, as I told, is rising, but it has not risen very much. It's just because of noradrenaline requirement and the hypoxemia there is some rise. Otherwise the potassium is high, the AKI has developed, and CRP is high. So once again, you will get around 2 to 3 minutes to read this. You need to be very smart with how you deal with this thing. So what are the issues here? The first issue is that you are dealing with a hospital acquired pneumonia in a post-op patient. There is no bowel ischemia. They have given you the organism, it's Pseudomonas. Secondly, the patient is worsened, shocked, hypoxemic, severe AKI, urea creat gone up, urine output is 5 ml per hour over last 8 hours. See, urine output 5 ml per hour last 8 hours. Here you can think about dialysis, not in the first vignette. And also the infective markers have gone up. The patient is still in metabolic acidosis, lactate is around 2. So lots of findings. You need to find it out in 2 to 3 minutes. So what are the priorities here? I have already given you what are the issues. Tell me, priorities mean the answer will be hardly 2 points or 3 points, not all the priorities, not all the issues. So what are the priorities at this point of time?
Management of hospital-acquired pneumonia, sir. Also, management of acute kidney injury requiring some kind of renal replacement therapy. Also, there is an evidence of growth of organism in the bowel. So that needs to be taken care of.
It's the same thing. Hospital-acquired pneumonia and the bowel is the same things, right? So yeah, you are taking care of that. What else? You are taking about the acute kidney injury. What else?
Hyperkalemia is a...
Yes, hyperkalemia has to be the first point here. It's 5.9. If you do not mention hyperkalemia here, they will immediately, if you do not mention hyperkalemia as the first point, they will strike off that yes, this doctor is unsafe for the ICU. Once this thought comes in their mind, it's very difficult to get this out of their mind, and they think like this. Okay, I have done 2 of the ESICM courses. There, the examiners have told in the discussion that if hyperkalemia is there and if the doctor is not mentioning it in the first 1 to 2 lines, we consider that doctor to be unsafe for the ICU. Do not fall in that trap. Potassium raised till I shall manage the hyperkalemia. All of us know that you need to give the anti-hyperkalemia measures here. And just because you have managed the hyperkalemia in one of the other vignettes, do not mean that you do not mean to correct it here also. Okay. So yes, so one was hyperkalemia and the others you mentioned the very correct. Acute kidney injury needs the correction here, probably requires hemodialysis. And third is the patient also requires this sepsis correction of the as per as Pseudomonas aeruginosa, for which once again need to assess the fluid status, sensitive antibiotics. If the noradrenaline requirement increases, add the vasopressin, give the high dose corticosteroids, that is as per the septic shock dose, the usual septic shock management. Once you tell this, start very confidently that you will give the anti-hyperkalemia correction, you will start the patient on hemodialysis after taking the nephrologist consultation, you will bring the nephrologist in the loop, and third is you will target the Pseudomonas and they will do the IV correction and antibiotic. They will not allow, they will stop you because they want to move to the next question so that you can score the marks. They are helpful in this regard, but they will not help you with the answers. Okay. So Will you start CRRT here or IHD? Like IHD is intermediate hemodialysis.
CRRT, sir, because patient is hemodynamically unstable,
Okay.
requiring adrenaline
So what will be the settings for CRRT here?
So dose of CRRT should be should be 25 to 30 mils per kg. In order to overcome for the downtimes, we set it at a higher dose. Ideal dose should be 20 to 25 mils per
No
kg.
need to tell these things. See, this is theoretical discussion. How will you prescribe CRRT means you will tell I shall start CRRT at 30 ml per kg. It cannot be 20 to 30. Either 25 or 30. Tell anyone. It will be accepted. Then move on to the next part. What else you will like to tell? You do not need to explain yourself unless they ask you why you set the set like this. You are right. CRRT dose. You are right. Absolutely right. Now let's move on to the next part.
30 mils per kg per hour. So this
Okay.
was a 100 kg adult. So this will come out with 3000 ml per hour. And then I will divide this dose 50% into dialysate and 50% in the replacement fluid. So 1500 will be the dialysate and 1500 will be further 1/3 and 2/3. It will be divided into pre blood replacement and post 2/3 and 1/3 I will divide.
What else?
And fluid removal, I will also target for fluid removal starting. It should be 1 to 2 mils per kg body weight per hour. So I will start
What
lower
else?
dose.
Yeah. I understood you. What else? In the
I
prescription.
will also target for hyperkalemia management, trying to prefer hyperkalemia and metabolic acidosis management, trying to prefer bicarb-based solutions and potassium-free replacement solutions in the CRRT.
Okay. What else?
Anticoagulant use.
Pardon?
Anticoagulant.
Yes. So what anticoagulant will you choose here?
Regional acetate anticoagulant or heparin?
No. What anticoagulant will you choose here means you will have to answer anyone. What will you choose?
Regional lactate.
Regional citrate anticoagulation.
Citrate.
RCA, right? Okay. What else, doctor? What else you need to do it here? What is the first thing that you need to do if you want to start a renal replacement therapy? That is actually part of the prescription. You need to secure the line, right? Yeah.
HD cath.
Yeah. See, this exam is like that. They do not want to know whether you know about this pre or post 2/3, 1/3, 60, 40, 50, 50 thing. They, as per them, what will be the CRRT? I'm telling you that. If you tell those that, then it's fine. They will probably realize that yes, you are actually prescribing CRRT and those things. That will possibly give you some extra credits if you would like, as I told in the end. But prescription of CRRT should include, first is line, securing the HD line. Tell them you will secure it in the internal jugular vein. Okay. Second is, as you told, the dose, 30 ml per kg body weight. That is the dose. Third is effluent removal. Tell them that initially I shall not give the effluent because the patient here is hemodynamically unstable. I shall start effluent removal once we feel that the patient is gradually stabilizing at around 1 ml per kg body weight, and we shall adjust accordingly. Then pre-post, if you want to, you can tell. You can tell that I shall divide it 60 to 40 pre-post. And fifth is the anticoagulation. So these are the 5 points that they are expecting to hear from you. Do not forget the lines. Do not forget anticoagulation. I do not think anybody will forget the dose or the pre-post or the effluent removal. Okay. And in hemodynamically unstable patient, tell that you will not remove the effluent first. You will let the patient stabilize, and then you will start the effluent at around 1 ml per kg body weight, which you can increase if the patient remains stable. These 5 points, and they will move on to the next question. So patient, so you have started CRRT. Patient developed, this is my long case in the EDIC. Okay, so these are the questions that I was asked. So it's not a made up question. Patient developed agitation and arrhythmia. ABG showed hypocalcemia. What is the reason? for hypocalcemia here? Tell me.
Maybe citrate
Citrate and
overload.
Okay. So how will you manage this patient? I mean, manage the complication.
By giving a supplemental calcium in the post-dilation fluid.
Yeah, in a post-dialysis thing. Yeah. So we'll give the supplemental. And what else will you do? First point is okay. Second point. You will reduce the citrate infusion dose, right?
Okay.
Yeah. So obvious. So these are obvious points, but these are the ones which carries marks. In the real exam also, I told what you told, that we shall supplement calcium in the post dialysis in the the line, and they asked me what else, and then I told that yes, I shall reduce the citrate dose also, and then they were happy and they moved on. So what does this mean? This means that they helped me. They if I had not told that, then they would have probably given me 1 out of 2, because probably had 2 marks. So not all the time they will prompt you. So try to answer the 2-3 points if you can again. So this is a vignette 3, small vignette, just go through it. Sorry. They had another part there. They asked me what will you do next, and then they helped me. Actually, they went back here and they told me that you have done this AKI CRRT management and you have corrected these things, started the antibiotics, patient is still deteriorating. What will you do next? In a post-op patient, even if you have done a CT earlier and if the patient is still deteriorating despite taking care of the other options, the answer is always once again a CCT abdomen with a CT angio. So I forgot to ask that question. I already showed you the vignette. So yeah, this is the second CT abdomen that they have done. Okay, so this is very tricky. We often think that yes, we already done a CT abdomen, so maybe they're asking something else. They're asking for the repeat CT abdomen. Now there is a focal hypoperfusion or descending colon and the proximal sigmoid. Again, they have done a CTPA. You see, they had done a, there is no P here, right? The second line, there is no P, so they have already done a CTPA there. Here they have again told that there is CTPA negative for P. This question was not regarding pulmonary embolism, but pulmonary embolism is once again a similar thing. If they repeatedly tell you that the patient is hypoxemic, requiring very high oxygen, requiring non-adrenaline vasopressin high dose, and you have ruled out PE once before, and again the similar situation occurred after 3-4 days, again you need to rule out PE. Again, you need to do an echocardiography. Again, you need to do a CTPA. Again, you need to assess for any clinical signs of pulmonary embolism and risk factors, whether the patient was on anticoagulants, whether it was stopped, whether it was adequately dosed, all these things. So these are recurrent question themes in the EDIC part 2 long case. Okay, yeah. So now the patient has developed a surgical abdomen, basically a hypoxic abdomen. An ischemic abdomen, and there is improvement of the consolidation of CT thorax. Blood culture now view E. coli and gram-positive cocci. So what will be your next step in management? Tell me. It carries a good 5 marks. So yeah, a big detailed discussion regarding this.
Do CT angiography of abdomen to see any thrombosis.
Yeah. I mean, you already done that. CT abdomen here means CT abdomen to CT angiography. Then there is a focal hypoperfusion, descending colon, and proximal sigmoid. We have already told you that. Now, how do you manage this patient?
So we can give any anticoagulants in the form of low molecular weight heparin.
Dose.
And dose is if the coagulation profile is okay, then we can give therapeutic dose 5,000 BD fragment.
Okay. After that, don't tell don't tell this brand.
For blood culture, we'll give the antibiotics for E. coli and gram-positive cocci.
Which antibiotics? Don't tell antibiotics.
As per culture sensitivity report.
Okay. Yes. As per culture sensitivity, that actually is a very good answer. That is the answer they are looking for. You will tell it that exactly as per that culture sensitivity report and as per the local ICU protocol. And then they will tell you. Then they will ask you what is the local ICU protocol where you practice. And basically, you will have to tell that first, then they'll tell you which antibiotic, then you will have to tell an appropriate antibiotic's name. So what will you give in this case?
For abdominal case, we can use levonadifloxacin.
Levonadifloxacin. Doctor, don't tell these
No.
higher antibiotics in this exam. Okay. So tell them that the patient was already on Pseudomonas treatment. We have not discussed what Pseudomonas management he was on. Maybe he was on. They start from basic antibiotics. Even if the patient is in shock, they have probably given a piptaz, in a piperacillin tazobactam or a beta or BLI inhibitor for the piptaz. For the Pseudomonas. So that will probably take care of the E. coli. Tell them that, and you will add something for the gram-positive cocci because of the blood culture in gram-positive cocci. So what is the starting antibiotic for gram-positive cocci when the patient is in shock?
Vancomycin.
We can start teicoplanin as the patient is having AKI and vancomycin is nephrotoxic. So we can use teicoplanin.
Yeah, any of them. If you tell her that you will start
We can use
if you tell
tigecycline in abdominal cases.
Yeah. If you tell that you will start the antibiotic as per the ICU culture protocol, ICU cultures and ICU protocol, then they will give you half the marks. Okay, and maybe they'll move on. They may not ask you the question, and then they'll give the full marks obviously. But if they ask you which antibiotics, then just assess the situation. E. coli probably the whichever antibiotic you give Pseudomonas that will cover. So tell them that gram-positive cocci, very rightly, teicoplanin, tigecycline, vancomycin are options. Vancomycin do not tell first in any exam, not in EDIC 2 especially. Teicoplanin is usually the drug of choice that they are looking for, especially as this patient is in shock. TG is also a very good option. Yes. So tell them this. Don't tell vancomycin. Okay, vancomycin is for more resistant cases. It's further away. So next steps in management you have discussed. So you have started some new antibiotics and you're waiting for the improvement, and the CT thorax is already improving. So do not need. So the Pseudomonas is responding. And what about and what else you need to do here?
If the abdominal symptoms are persisting, then we may need to do the diagnostic laparotomy. And if there is any
already there is an exploratory laparotomy.
yeah.
Okay. So there are two parts here. One part is the acute abdomen, the abdominal part, and second part is the sepsis part. We've already taken care of the sepsis part as per our discussions. The second part is the abdomen part. Here, you have to take the surgical opinion and you have to prepare the patient for laparotomy. There's nothing like waiting for the patient to improve. Post-op patient, focal hypoperfusion or descending colon, proximal sigmoid, patient is deteriorating, 70% O2 requirement, lactate rising, nodal rising. There is no scope to wait. Not in the ICU, real life ICU, not in this exam. So surgical opinion, preparation for laparotomy. That is the answer. And the antibiotics. So now the post-surgery, surgery has been done. The patient is hemodynamically stable. The nodal development has come down and is on mechanical ventilation. It's day 7 of ICU stay. Okay. The laparotomy was done and the appropriate things were done. So see, they will not ask you about the laparotomy part, obviously. But now what they want to ask you is that there are some problems to winning this patient because the patient is now more stable. It's 7 days. So now you think about winning the patient. So now the patient relatives want to know when the patient can be weaned out of the ventilator. So you tell them about tracheostomy, that the patient may need tracheostomy because it's already day 7 everything. So how will you counsel the patient relatives regarding this? You see, in these long cases, the first vignette, second vignette, third vignette will be about the case itself. The first two vignettes usually. The third vignette will usually be about a CRRT or an ECMO or about a procedure like a pleural, you have to insert a pleural drain, you have to tap an ascitic fluid, or a lumbar puncture, something like that. The fourth scenario will be about some complications, as we have discussed here. management of atrial fibrillation, management of a persistent septic shock, management of post-op complication, management of these embolism things, or a bleeding patient, something like that, which will be related to the initial case but will not be discussed initially. They are able to discuss about the investigations, management, and these sort of things. And then in the last vignette, there will be usually 5 to 6 vignettes. Last vignette, they will ask you either about a tracheostomy or about the post, about counseling or about an end of life care. So here they are asking about tracheostomy. So tell me how you counsel the patients about a tracheostomy.
Okay, let me try. I will call the relatives and inform them about the progress that has been achieved so far. But that the challenge we now have is, taking him off the ventilator. And I'll counsel them, inform them that we do not desire to keep him more longer than necessary on ventilator because of the likelihood of developing ventilator-associated pneumonia. And so we need to take him off. And that one key way that of ensuring that he's taking off ventilator as quickly as possible is to give him to do a tracheostomy. And I'll tell them about the pros and the cons of the tracheostomy, some of the side effects, and then the measures we could take to prevent those adverse effects.
Yeah, very nicely done. That is how you answer this question. Okay, I shall discuss about this. And the first thing is that habit of the candidate is that they try to tell about those short forms, spikes and those things. Don't do that. As doctor here rightly pointed out, as doctor has already rightly pointed out, you need to first is that we need to come to a decision about whether you actually want to do a tracheostomy or not. That will be a internal meeting about the doctors or treating team, ICU doctor, consultants, and about the surgeon and about the prognosis of the patient. We need to come to a conclusion. Yes, then we shall call the patient. Then we shall call the patient's relatives. Then we shall call the patient relatives, and we shall sit in a nice, comfortable room. We shall not let the patient relative wait. We shall call around 3 to 4 of them, and maybe 1 or 2 of us who actually knows about the whole case scenario will join the meeting. We shall ask them how much they know, how much they want to know, and do they know why you have met here or not. And then we shall tell them that this has happened in brief, if they do not know. And now the patient's condition is this and this, and you think that the patient will not be on the ventilator easily. To reduce, and we shall going to go for tracheostomy. Do you have any idea about that? They will tell no. Sorry. Then you will describe in plain language what tracheostomy is and why it is important and what are the advantages. They will ask you that whether it will help in curing the patient earlier. You will tell that no, it will not cure the underlying abdominal cause or the sepsis, but it will make the patient more comfortable. It will allow for a better mouth care, better drainage of secretions, and it will probably reduce the need of the analgesics, make the patient more awake, help in mobilize the patient, help in weaning off the ventilator from there. So they will not ask you this much. They will just want to know whether you are doing a meeting beforehand to come to a conclusion among yourselves. Nice closed room, how many people you are calling, whether you are telling the truth, and whether you are doing it in a dignified and simple manner or not. That's all. It will hardly get 2 to 3 marks. This end question, if it is about the counseling and how you describe the tracheostomy, it will carry another 2 to 3 marks. So again, 5 marks for this. So that's all for today actually, and I hope this was my own EDIC case that I did the last month only. So I hope this session was useful. We can do some more sessions later on based upon my other cases and also about the case ECG findings on a on this interactive fashion. But EDIC 2, if it is not interactive class, it's useless. It's absolutely useless if it's not an interactive class. thank you the people who participated. I hope that others make themselves more audible from next class onwards, because it will help you. Otherwise, if you stay quiet here, you will not be able to answer even if you know in the exam scenario either. If you have any questions, you can share it in the group and I shall be happy to answer. And till we meet again in the next class, goodbye.